and possibly to adapt our treatment to what we see. So why do we want to perform an imaging follow-up? Because flow diverter is working by promoting the thrombosis in the sac, and this is a progressive process, as you know. It takes between 3 and 12 months. We published this paper showing the thrombose of the aneurysm, progressive thrombose of the aneurysm we saw on MR. So we have to understand and we have to know the signal. We have to understand with MR what is a flow inside the aneurysm, what is a slow flow, and what is a thrombus, to understand clearly with MR. But not only, I think that we need to do DSA for the patient, at least at 1 year. Why? Because first thing, we need to decide when to retreat an aneurysm. If we have a partially occluded aneurysm with flow diverter, when do you decide to do a new treatment? We know that, again, we have something like almost 20% of partial occlusion, and we may have delayed rupture post-flow diverter. So there is a rate of treatment, something between probably 4 and 6% of patients have a retreatment. And even it has been reported that you can have a recurrence of aneurysm after total occlusion. So this is a reason why you want to make a follow-up, imaging follow-up. Something else, so this is about the sac, but also vascular assessment. We saw that, and I will show you some cases, that we have complex vascular remodeling after flow diversion. We have instant stenosis. We have sometimes parent vessel occlusion or side branches stenosis or occlusion. So you may decide to change your medical treatment according to this. So how to do it? We have very simple cases. This is unruptured left internal carotid artery siphon aneurysm, 9 millimeter with a small neck. So if you treat this patient with a flow diversion, it's straightforward. You see AP view of the angio before. This is what you see on MR angio. And when you follow up, you see the results with angio. This is results with angio, placement of flow diversion. And this is what we see with MR angio. So this is a tough time of flight technique. And you see that there is no aneurysm to be seen in this place, so complete shrinkage and cure of the aneurysm. So this is an easy case. You can do almost the same with this one. It's also left internal carotid artery aneurysm, but this one is bigger. The neck is bigger also. This is the treatment of the aneurysm, angio follow-up at 1 year. And if you look at this MR, you see, you cannot see exactly the vessel at the level of the stent, but you see that there is no aneurysm left. You see nothing here, and you have a good treatment. And if you perform GADO MR, you see that you don't see anything. There is no remnant of aneurysm. So in these cases, it's easy to make a control angio and control MR, and you see that the aneurysm is completely treated. But we may have more difficult cases. So MR is okay in some cases because you see that the aneurysm disappear. But in this case, for example, this was a patient, a young patient with aneurysm at the end of the right internal carotid artery, and so the aneurysm is a little bit irregular. It's not exactly at the end of the internal carotid artery, but slightly on A1 segment, which is a little bit different. It's not in front of, it's not working very well. It's not exactly the aneurysm is not exactly at the end. It's more, if you look carefully, it's more on the A1 segment. So this kind of aneurysm is not so easy to treat. So I was thinking, do I have to place some coils? But sometimes it's not so easy because you don't have a very stable situation to place the coils. So eventually decided to place a flow diverter at the end of the internal carotid artery going to the M1 segment. So we checked before that there was a cross flow between the left and the right. So the anterior cerebral artery will be taken in account by the left. And so we performed the procedure, which was, it's easier to do such a procedure than to place some coils inside. Okay. So look at, thank you. So this was the placement of the device here. You see that the flow diverter is here from the internal carotid artery to the M1 segment, covering A1 and covering the aneurysm. So we expect from this that probably part of the A1 segment will shrink, but also the aneurysm. But after 2 months, the patient went back with acute headaches, and she was very anxious, and there was a discussion at night, during the night was discussion about a possible weakness of the right upper limb. So she had the CT scan, and then she has MR. Eventually, she didn't have any neurologic deficit, but you see, we can compare, and you see what was going on with the CT. So you see that there is no infarction, but you don't see exactly what is going on. If you look at this, this is a coronal view, but you know that CT scan will give a lot of artifacts because of the stent, and you don't see anything. This was MR, same thing. Difficult to assess the end of the internal carotid artery. It was said that there was a stenosis at the end of M1. You look at here, probable stenosis here, and very difficult to assess what was going on angio-MR, on time of flight angio. So we can say there is no bleeding, no ischemic lesion, and we are discussing in-stent stenosis. At least there is no hypoperfusion on MR. So we performed the assay, and this was the result. You see, so A1 shrank. You see that the A1 segment was very small. You see that there is still some filling of the aneurysm. There is minimal stenosis at the end of M1, and this is to be compared with the time of flight MR. So time of flight demonstrated some stenosis, but it was very, very slight here. MR didn't demonstrate the aneurysm that was not completely treated, but we are early. It's only 2 months. Vaso-CT was performed during the angio, and it gave us very good results, very good information with filling of the aneurysm, the good position of the stent, patency of the vessel. CT was not very good. We may discuss filling of the aneurysm. So angio in this case was really, DSA was really efficient, really necessary to understand what was going on. And so we kept the patient under antiaggregant, antiplatelet therapy for more than usual. So this DSA was necessary. We keep the patient under Plavix, so keep the Plavix more than usual. We can say that MR overestimated the stenosis and failed to demonstrate the remnant. And CTA was not very good, but Vaso-CT was very nice to understand what was going on. So if we look at some other difficult cases, so not all cases after flow diverter implantation are simple. We saw before very simple cases when you place the flow diverter, patient is going okay, and you do MRI, you see that the aneurysm disappeared. So if you look at this case, I think it was a very complex case, for me at least. This is a 60-year-old patient with a posterior communicating aneurysm. Patient complains of vertigo, and at a CT scan that demonstrated this aneurysm. So this is right internal carotid artery. This is the left with the aneurysm, and this is the right vertebral artery. So this is the aneurysm. So first thing, you may discuss, do we have to treat this aneurysm? I think it's quite a large aneurysm, so I think it was necessary to treat the patient. Then there is a very big fetal posterior communicating artery coming from the aneurysm. So how to treat this aneurysm? So I was really wondering what was the best treatment for this patient. Really not easy to treat the aneurysm. There is no PCOM from the vertebro-basilar system. So there's a risk to occlude the posterior communicating artery, and the morphology is not so easy. So ideally, you want to treat something like this. You want to treat the aneurysm, but to keep this branch open, and so the anatomy is not very easy. So probably, if you look back, it was probably a strange idea, not probably a very good idea at least, to treat the patient with a web. So I decided to place a web. So if you look at this picture, I think that going with a catheter and place a web here could be a good idea, and to occlude this sac. So this was performed. So the web was here, and at first it's not a bad result, because the branch is here. There's a small remnant of aneurysm. So ideally, you may think that you want everything from here to be treated. So it's not quite complete, but it's not so bad. But again, we have shrinkage of the web, and after a while, we have a recanalization of the aneurysm. If you look at the lateral view, you see the aneurysm recanalized, and if you look here, again, you have a recanalization. So because the time was going on, so it's 2 years later, as the first time, I was reluctant to place flow diverter in front of the posterior communicating artery, but then I think there was no other option than to do this. So I placed 2 flow diverters in front of the aneurysm, and it went well. And but the patient was sent back after some time. I think it was another year later. The patient was sent back with this, and showing that, and they said there is a recanalization of the aneurysm on MR. This is on CT. There's a movie. I hope it will be okay. Very difficult to access on this movie, on this CT angio. You see that something is going on. You can see the web here. You can see the vessel, but it's very difficult to understand. At least the internal carotid artery is not closed. The patient is doing well. This is the web. You can see the web in here. And you don't see exactly, we don't know exactly what is going on here, what is the branch. Okay, so we did angio, and angio was very strange. You should look first at this picture. This one is the left carotid artery, because we said we wanted to understand what was going on with the aneurysm, so we did angio from the left. And you see there's no much aneurysm seen. Aneurysm is almost completely open, but we don't see the posterior communicating artery. It's not seen on this, so I thought it was completely thrombosed. because of the flow diversion. But when you make an injection from the right, it's a very strange situation. If you look at the right, you see, thank you, you see the right A1 segment, the left A1 segment, then something which is probably the internal carotid artery. You see part of the communicating artery, but you can see that the posterior communicating artery, the posterior cerebral artery from the left is taking from the right, so going this way to the posterior communicating and to the posterior cerebral artery. And a very small part of the aneurysm is still filled by the right. And if you look carefully, you see that, so I told you before we placed two flow diverter, and there is a gap. There is a small gap here between the two, and the flow is going through at the level of the gap. So there is not a complete placement of the flow diverter. So there is a gap between the two of them, and the flow is going through. So the patient was going well. Posterior cerebral artery is open, and there is minimal filling of the aneurysm, almost nothing, because you see we have already the web here, a very small filling of the sac, and this is the posterior communicating. So at this time, I decided to do nothing, because I may go inside the flow diverter and use a balloon and change the flow and probably stop the flow inside coming from the right, but then maybe I will close the posterior cerebral artery. So we need DSA, and we have sometimes very strange vascular remodeling due to the flow diversion. If you look at this case, this is a case from Charlotte Barbier from Caen. This is atheromatous stenosis at the end of the internal carotid artery, and this is before treatment, and the patient bled, and there is a blister-like aneurysm, very small one. She placed a flow diverter here, and this is a control, this is time of flight, this is contrast-enhanced MR angiography. Very difficult to understand, but if you look at the DSA, you see that still some stenosis, but you know from the beginning there was a atheromatous stenosis, and there is instant stenosis from the stent, so we are waiting because you know that this instant stenosis is maximum after 6 months. We discussed the case yesterday, so we wait and we hope that the case will be better. The patient is asymptomatic, so we don't do much. Another case with a small aneurysm that bled, very small, difficult to treat. So it was again treated with a flow diverter placed in the siphon. MR is difficult to interpret, it's difficult to understand if the aneurysm is still here. And if you look at the angio, performed 6 weeks after the procedure, you see that the aneurysm is still patent, and the flow diverter is not fully opposed to the wall. And in this case, probably it's better to perform a new angioplasty to use a balloon. It's a very simple procedure because it's easy to go inside the flow diverter. It's like a tunnel. You go inside and you inflate the balloon, and then you may be able to have a better position of the flow diverter and treat the aneurysm and avoid some complication. This is another case. It looks a little bit like the first one. So it's a large aneurysm. The morphology is a little bit different. You see left internal carotid artery. The aneurysm is large, and there is a fetal PCOM. So placement of flow diverter. But in this case, it's a different case. The patient was found hemiplegic. There was a CTA and a CTA. It's difficult to understand exactly what is going on with the CT and even the CTA. We know at least that the patient bled. And this was what I told you yesterday. I think we may consider that this is a watershed infection. You know, this is a place when you can find a watershed infection, low perfusion. So if we have a problem of flow, if we have a reduced flow inside the internal carotid artery, you know that this will be the weak point. And because you gave the patient dual antiplatelet therapy, there is a bleeding at this place. So I think this is logical, you know. It's not only dual antiplatelet therapy and the patient, not that the patient is hyper-responder, but it's also that you damage the brain. And if you damage the brain and you give antiplatelet therapy, you get bleeding. And yes, there was, you know, patient was operated from the hematoma, but antiplatelet therapy was stopped, and you see occlusion of the internal carotid artery. Anyway, I think there was a reduced flow inside the left internal carotid artery, and it was a cause of the bleeding. This is the angio, so it's better to perform the angio to try to understand what is going on. And you see that in this case, part of the aneurysm is still open. So flow is coming to the M1, to the left M1 from the right, and part of the aneurysm is still patent. But in this patient was a bit difficult to do something because the patient was already hemiplegic, so we have to wait. This was another case. So again, sometimes you treat small aneurysm, and it may be difficult to follow up with MR, and it could be difficult cases. This was a patient bled before, so has a subarachnoid hemorrhage, and the aneurysm was here, very small aneurysm between, at the end of the internal carotid artery, exactly the beginning of A1. So we have a bleeding, we have a small aneurysm at this location. It was treated by my colleague. We have good, excellent treatment at the beginning, at the acute phase of the subarachnoid hemorrhage, complete occlusion of the aneurysm. But when we did the control, we saw that part of the coil went outside, and there's still a remnant of the aneurysm. So completely treated from the beginning, and then we had recanalization of this aneurysm. It's a small aneurysm, but we have like 50% recanalization. The patient bled before, so we think that we have to treat the patient. So I did this, and I went with, I did this procedure. I went inside the aneurysm and placed a new coil. But you know that the neck was not so small when you compare the neck to the sac, and eventually the coil went distal. So we have migration of the coil. It went outside of the sac, inside the internal, inside the anterior cerebral artery, very distal. So I told you yesterday we can remove this coil with a stent, thrombectomy stent. So this is what we did. We use a small echelon 10 microcatheter inside the anterior cerebral artery, and then use a small trevo 3x20 that you can go and push through the echelon 10. So it's not so difficult. It's not 27 or 21. It's a small catheter. You go with a small stent, and the coil was removed. So now what can we do with this aneurysm? So I decided to place flow diverter. This was a P64. And you look, this is before placement. This is after placement of the stent. So in this case, we had the coverage of the M1. But with time, I think it's okay. I don't mind covering some vessel, for example, M1, A1 vessel segment, and you see that it's not so bad. And it was a good result, and we have complete occlusion of the aneurysm. This is MR, this is DSA. You see that there is stenosis, it's a little bit reduction, decrease in size of the M1 segment, but the patient is asymptomatic and there is no problem. These are distal. I have two distal occlusion of aneurysm. This is a patient who bled with a dissection of a distal branch of the middle cerebral artery. You see before treatment, you see the result. It was angio before treatment, you see the aneurysm. And we had implantation of a flow diverter. You can see here, distal. And this is a result at 1 year. Again, it's difficult to evaluate with MR. So I think at 1 year, we really need to do angio, and we have a good result. The artery is not perfect. We have some kind of instant stenosis. You see a little bit of stenosis here, but it's not too bad. And another case with distal implantation. This is Vista Baby from BALT. A very soft device. It's very well seen, very easy to place, and it was placed inside the distal branch with a good result. So why not perform DSA? Because some people will say that DSA is too invasive because you use radiation exposure. We have nephrotoxicity from contrast media. We may have complication from angio, but overall it's not so bad, I will say. If you are afraid of all this, we can decrease invasiveness of the angio, of the DSA. We can go through radial. Sometimes we do control with radial, and the patient is going after 3 hours, is able to walk. There is less complication. We use very minimal radiation exposure for the patient and very low amount of contrast media. And I think it's interesting to do DSA because usually you perform the procedure, so you know what are the working projection, you understand well what is going on, and you can work on this. So some people will say that it's better to do only MR. I think not exactly, and usually the DSA is considered to be the gold standard of follow-up of treatment of flow diverter, for example. In this series, you see that DSA is a gold standard. In this series, they said that, in this paper, they say that after one good DSA, it's okay, but you need at least one DSA that show occlusion of the aneurysm, so you don't need to repeat the DSA. And there was a meta-analysis saying that same thing, you have to perform at least one DSA, probably at 1 year, and then if it's okay with one DSA, you can follow up the patient with MR. We know that all these publications are difficult because there is a small number of cases, technique of DSA, technique of MR are different, and sometimes you have an interval of time, a gap between the DSA and MR, so it's difficult to compare. If you perform, like in this case, here we have almost 3 months, more than 3 months between the DSA and MR. It's difficult to compare because things can change and vary with time. We saw that there was publication about contrast enhancement of aneurysm sac. This was thought to be a recanalization, but when you perform DSA, you see there is no recanalization. We need to evaluate instant stenosis, and we discussed yesterday of instant stenosis. You see important one. The patient is asymptomatic. It's 6 months after placement of the stent, so we're still waiting for control. We keep the antiplatelet therapy for the patient. So in pipeline stenosis, if you are interested with subject, you can see the literature. We have a maximal instant stenosis at 6 months, and then we have decreasing. We have a rate of instant stenosis, and the fate of side branches. So all this that we discuss, side branches, instant stenosis, all this information you can find and you can evaluate with DSA. So in conclusion, I think that we are improving the results of flow diversion, going from more than 10% to less than 5%, maybe 3-4% of complications, still too much, and we have to improve again our technique. But now I will say that the real problem is to improve, to increase the rate of success or correct occlusion. Total or subtotal occlusion is still too low. 80% is not enough. And definitely we have to see the patient for a long time, DSC at 1 year, and we need to follow up the patient and to change medical treatment if necessary, sometimes to retreat the patient because there is incomplete occlusion of the aneurysm. It's difficult to decide, but if you have partial occlusion at 1 year, I suggest that you can treat the patient again to occlude the aneurysm. Thank you.